Good morning to everybody. We are so happy to have Professor Boris with us in our HBP Cafe. He's a well-known international interventional radiologist. He's the head of radiology in Montpellier. He's the president of the European Society of Radiology. He has many publications, I would say more than 350. And he's a pioneer, in fact, in interventional radiology, especially liver deprivation technique and radioembolizations. So we are so happy, Professor Bio, to have you with us here, and the place is for you.
Thank you so much for your very kind introduction. So here, I propose to review with you two different topics, because we have many very interesting topics, including the newest one. And when we discussed with Professor Panaro, he got the idea to mainly focus on liver venous deprivation. And the second topic, a little bit oriented, as you will see, on Y90 radioembolization, especially for HCC. So just as a short introduction for venous deprivation, because you all know, because some of you and most of you are surgeons, that there are conditions to make the patient resectable. They are clearly indicated here, but this one, enough future liver remnant, is the main limiting factor to achieve R0 or even R1 resection when pulling all patients all together. The reason why we need to take care particularly of that, and as you know, a too small FLR means that there is a high risk of post-hepatectomy liver failure, which is the main cause of death following major resection. To increase the future liver remnants, the standard of care so far is certainly portal vein embolization, which, as you know, was described now 40 years ago, so a long time ago. And if we look at the literature here, we have some papers published in the higher journals. You have here two systematic reviews and one of the latest randomized controlled trial. The results are more or less the same. And at the end of the day, PVE works very well, because 80% of patients can be resected after PVE, which is a very good result and something probably we need to keep in mind. But at the same time, it means that 20% of patients can't be resected. And there are two main reasons for that. And the most important one is tumor progression. So among these 20%, 15 is related to tumor progression during the post-PV period, which may be sometimes very long, because as you know, the liver takes time to regenerate. The second reason is obviously insufficient FLR volume. So if we want to improve portal vein embolization, we would like to. I'm sorry?
No, can I ask everybody to mute his microphone? Sorry, Dr. Boris.
No problem. Okay, thank you. So, these are the two main reasons, meaning that if we want to improve this technique, we probably want to get technique which is able to provide us with larger amounts of FLR gain, but more importantly, to provide it quicker. Because it's probably also interesting, as you know, you are resecting the patient something like 3, 4, 5, 6 weeks, sometimes more.
Or should I go in the office?
After portal vein embolization.
Listen to it? Okay.
And that's the reason why many techniques have been proposed to improve or to replace portal vein embolization. And one of them is venous deprivation. What does it mean? By definition, venous deprivation means that you will embolize at least one major hepatic vein in addition to portal vessels. And what is the rationale behind? Maybe it can be explained on this very simple graph. You have here the microcirculation of the liver, the normal microcirculation of the liver. What happens if you do occlude one major hepatic vein, then you still have the arterial inflow going to dilated sinusoids. It becomes dilated because the outflow is obstructed. And then blood flow goes through the portal vessels. Portal veins act as draining vein in this case. And this may be interesting after PVA to counteract persistent minute portal inflow, which may be seen in case of incomplete or too proximal portal vein embolization. We have a typical example here from the literature where we had portal collaterals due to too proximal PVA, which may also happen in case of portal vein negation. So with venous embolization, you can reverse the portal flow, which could be interesting. But the second point is for segment 4. And maybe it's easier to understand from this typical example here. Here, this patient underwent venous deprivation. So we occluded right portal vessels, right hepatic vein, and middle hepatic vein. And in this case, segment 4 outflow is through 100% through the middle hepatic vein, explaining that at day 1 on CT, you can see that it becomes congestive. And this congestion is decreasing slowly, but progressively over the next 2-3 weeks. But during this time, segment 2-3 are increasing their function a lot due to the embolization. But what is interesting from this mebrofenin study is that segment 4 function is not increasing and is even decreasing, meaning that this technique, embolizing the middle hepatic vein, could be a good alternative to segment 4 PVE, which, as you know, is a technically challenging procedure and risky procedure. That's the second point. But the most important point for the rationale is here. If you previously embolized the portal vessels and if you add hepatic vein embolization, then what happens? The arterial inflow is reduced, not suppressed, but reduced, owing to the hepatic arterial buffer response. And meaning that in this territory, with portal vessels already embolized and arterial inflow reduced, you will get more damage in the embolized liver, and as a consequence, greater regeneration. And now we have proofs, again, based on mebrofenin scintigraphy. We looked at what happened in the embolized liver after PVE and what happened in the embolized liver after LVD. And things are totally different. If you look at after PVE, the function of the embolized liver decreased by 20%. If you look at what happens after LVD, the function is decreasing by about 40%, meaning that the functional damage after LVD is doubled than that after PV. And this may explain why LVD can bring greater regeneration in the contralateral lobe. That's the rationale. Just some words about the technique. We initially described this full transhepatic approach where we first puncture under US guidance the right hepatic vein here. Then we insert a micro guide wire that we leave in place before performing the portal vein embolization part with glue, because as you know now, glue is the standard of care. That's been shown in a randomized controlled trial last year. And so we used 3D road mapping to make sure to complete embolization while avoiding, obviously, the left portal vein branch. And once the PVE part is performed and completed, then we go back to the micro guide wire left in place here, then to introduce sheath, and then to deploy a plug. The plug is coming. This plug is objective is to occlude the proximal part of the hepatic vein. We usually use ultrasonography to position the plug adequately. You have here the vena cava and here the plug. Again, you have here the vena cava. You can see here the plug. And we pay attention to keep enough place for you to facilitate further surgery. And once the plug is deployed, the problem is that we can see very, very quickly these kind of collaterals developing and enlarging. And these collaterals here on these collaterals here. And they are very well known. There are many, many anatomical works on that, and they're very well known, especially in the context of Budd-Chiari syndromes. The problem is that most of them, not all of them, but most of them arise from the very distal part of the veins. So if we want to avoid them because they will circumvent the plug, making its deployment useless, if you want to embolize them, we need to use liquid agents in addition to the plug. That's the reason why once the plug is deployed, we also inject glue again behind the plug immediately after plug deployment, just to make sure that these collaterals are not too large or too developed. And we are occluding very slowly, very cautiously, the distal venous branches. You can see the distal venous branches progressively occluded, as well as potential collaterals that may arise. And the objective at the end of the day is to stop both the venous inflow through the portal vessels and the venous outflow through the hepatic veins and their branches. We reported the first results of this technique in 2016, sorry. In this paper, we showed that it was a safe technique. We had no complication, very good increase in terms of volume. And when we discussed with surgeons, including Fabrizio Panaro, he told me, okay, the hypertrophy seems to be much higher than we usually get with portal vein embolization. So please continue. And the second point, which probably was more important, was the post-operative recovery period after, for example, extended right hepatectomy. The patient had a very good outcome, really comparable to a simple appendicectomy, as said by some surgeons in Montpellier. And that's the main reason why we decided to expand the concept to extended LVD, where we embolize not only the right, but also the middle hepatic vein, in addition to white portal vessels. You have even such atypical cases. This is an atypical case where in this patient we had two main right hepatic veins, one middle, one accessory right, and right portal vessel. Everything was embolized using the technique I showed you previously. And if we do an MR scan of the liver at day one, it's interesting to note, you have here in red portal vessels, you can see that they are all embolized and occluded. And in blue, you have hepatic veins and their branches, including here the accessory right, and everything is occluded as well. That's the reason why we coined the term venous deprivation. At the beginning of our experience, we showed very important hypertrophy in the future liver remnants. You have a typical example here in a very short period of time, nearly comparable to what is observed with ALPS. Nearly comparable because ALPS still remains, in my view, the most efficient techniques in terms of volumetric gain. But things are totally different in terms of functional gain, because in this case, we observe very, very impressive and very fast functional increase in the future liver remnant. If you look at this SPECT CT, at the beginning, the function among the liver is obviously homogeneous. After venous deprivation, you can see this kind of functional switch from the right to the left lobe of the liver, so from the embolized liver to the non-embolized liver. And we got even more functional increase than the volumetric increase. And at the beginning of Can you hear me? Can you hear me?
Yes, we hear you.
Okay, sorry, because I have some error messages. Okay, I'm sorry. So we had some deep asthenia at the beginning of our experience, and this was explained. By that. We could see that this technique is highly energy demanding because of the intense regeneration caused by venous deprivation. The reason why we decided to give all the patients, high doses of vitamins and ions, and especially phosphorus. And with this kind of supplementation, we did not meet this complication anymore. That's something important, and we think that giving vitamins and ions is really helpful to help the liver to regenerate. And now we are probably 5, 6 years afterwards, and we can see several studies published by different teams comparing PV with LVD. And all but one, there's only one here, just published this year with very small population. But anyway, this study is negative. There is no increase. But for all the others, LVD outperformed PVA in terms of volumetric gain. Interestingly, if now we take a look to what happens after surgery, which is also a very important point, and if we pull the data coming from all these series, you can see that the risk of complication, major complication after surgery is lower when the liver had been prepared by LVD versus PV. But more interestingly, the risk of post-hepatectomy liver failure is much lower after LVD than after PV. That's in my opinion, a very important point. The second important point is the function. And unfortunately, in the literature, we have only one study. That's our series we published 2 years ago, where we compared PVA to LVD. You have here the results of serial measurements. So we did a SPECT CT at day 0, day 7, day 14, day 21 for both techniques, and we tried to compare them. And as you can see, there is a huge difference between LVD and PVE. But more interestingly, maybe, if you look at this figure, as early as 7 days after preparation, we got a little bit more than 50% gain in the future liver remnant function. And interestingly, the Lille team in France published the results of regeneration and recovery after hepatectomy itself, and using the same technique, the exact same technique at the exact same time point, they got only a little bit less than 40% at day 7. It's really interesting because it's a little bit unexpected, but with LVD, liver regeneration is a little bit more important than after hepatectomy itself. So it means all these results are probably are interesting because they probably show that there is a bright future for this technique, even though all these data are retrospective, and we need to be cautious with retrospective data. And that's the reason why we have now several international initiatives. We have the Dragon initiatives, an international group which aims to collect data in order to eventually conduct trials. You have the European registry following the model of the ALPS registry. And we have in France this randomized control trial with now 72% of patients accrued, where we compare head-to-head PVE and LVD. And then I hope that from these different initiatives, we will refine and define the place of this technique among the liver augmentation techniques. That's where we are quickly with venous deprivation. The second topic Fabrizio asked me to discuss a little bit with you is about Y90. It's a very important technique, which from the United States it's a very old technique, but for Europe it's more recent, and the results are becoming more and more attractive, as you will see. Just one slide for rationale. The objective is, as for TACE of HCC, is to take advantage of the purely arterialized tumors. Tumors only have their supply from arteries, whereas the normal parenchyma is mainly supplied by the portal vein, as you know. Meaning that if you inject Y90 in arteries, you will probably be able to cause radiation to the tumors and much less to the non-tumoral liver. That's the rationale. And for this treatment, and I think it's the most important point, we have a simulation phase. And that's probably the only treatment, maybe with also SBRT, where we have a simulation phase. And as you will see, it's a very important point for this technique. So how does it work? First, we do an angio and we look for the feeders of the tumor. And then we inject MAA and we do macroaggregate of albumin tagged with technetium. And the objective is to perform a SPECT CT and then to order a dedicated activity. And we go back between 7 and 14 days later, and we do the exact same catheterization to inject Y90. If we look at the literature, because it's very important, the story of radioembolization at the beginning is negative. If we look at this trial, this is a French trial, this is a randomized phase 3. We tried in this trial to compare Y90 to sorafenib, which at this period was the standard. And as you can see here, the trial is negative. No difference in terms of overall survival, which was the main endpoint, both for ITT population and per protocol population. But there are some comments we can make. The first one is 22% of patients who were randomized in the radioembolization arm did not receive radioembolization. This is a huge number and very, very atypical in the field of oncology. And probably this has strongly influenced the power of the study. This is the first comment. And I will try to explain you why we have so high number of patients who did not receive Y90 at the end. The second point is, if you look at the ITT population and the treated by Y90 was only 8 months, but now if you look at the per protocol population, meaning only those patients who actually receive Y90, the median overall survival is nearly 10 months. This is just a signal in favor of Y90. It means that when you consider already the patients who underwent Y90, their survival is better than if you consider all patients who were randomized and with this 22% eventually not treated by Y90. That's the first comment. We have a second study, sorafenib, which is the exact same study, Y90 versus sorafenib, and the results are exactly the same. The study is negative again. And again, if you look at ITT population versus per protocol population, the OS is 8.8 versus 11.3. So again, there is a signal that when you focus on patients who actually receive Y90, the OS seems to be increased, but the trial is negative. And again, here, look at that. Nearly 30% of patients did not receive Y90, whereas they were actually randomized in the Y90 trial. It is really a big problem. And now if we go back to our daily routine practice, it's amazing to see that phase 3 trials are negative. But if we look at these patients, and these are not case reports, we have many, many, many patients like that with huge tumors, only one session of Y90, and a very good result. The patient is still alive years afterwards. You have see very infiltrative HCC with portal vein invasion, another one here. And these patients are still alive, some of them 7, 8 years afterwards. So there is a discrepancy between the negativity of phase 3 trials and what we can see in our centers, not for all patients, but for a large number of patients. Why? Now we know why. Because if we look at how our colleagues, radiation oncologists are working, they are doing simulation CT, contouring, dosimetry, and planning. But more importantly, they are following very simply 3 rules. The first one is they want to irradiate the whole tumor, not only a part. And in these trials, many patients were treated only in a part of their tumor. So obviously, the results was not very good. 2, they want to spare at-risk organs. And in these trials of Y90, the problem is that many, many patients received Y90 in their whole liver, meaning that we also delivered radiation to the normal parenchyma with toxicities. And the last point, and last but not least in this case, we know very well, this is a very basic principle in radiation therapy, that we need to deliver a tumoricidal dose, meaning a dose exceeding a threshold. Below the threshold, we have no effect. Above the threshold, we have an effect. And this is a very important point. And actually, when they went back to the SARA trial, remember, it was negative. But when they looked at the dose actually received by the tumors, they could separate the patients between those who received a high dose versus those who received a low dose. And the overall survival was completely different. And this is completely in line with the basic principle that I showed you previously. So dose matters. And in France, we conducted this trial published in Lancet Gastro last year, where we randomized patients between a personalized dosimetry, meaning dosimetry where we want to deliver an efficient dose to the tumor, versus standard dosimetry, meaning dosimetry used in all of these phase 3 trials, negative. As you can see, inclusion criteria showed very, very poor prognosis tumors with frequent portal vein invasion, with very large tumor, more than 10 cm in most cases. And despite that, the trial was very positive. We had to stop it at interim analysis because the objective response rate was 71% with personalized dosimetry versus 36% with standard dosimetry. And there was a huge difference. And even in overall survival, it was a secondary endpoint. With personalized dosimetry, we got nearly 27 months OS, which is currently unprecedented for any systemic treatment. So here we could see in this trial that the phase 3 trials we were conducted previously were poorly designed because there was no dosimetry included in this trial. And now we understand why they are negative. And based on these results, now there is more and more interest in Y90, and we are treating more and more patients, even though probably we need a new phase 3 to be able to insert Y90 in recommendations. But in our daily practice, especially in Montpellier, we are using more and more workup phase, the simulation phase, to select very good patients for Y90. And as you will see, we have very interesting results. Because look at that, if we focus on portal vein invasion, which is a big problem, with sorafenib we had 8 months overall survival. With the most recent drugs, atezolizumab, bevacizumab, we have 14 months. But with radioembolization, we had 23 months, much more than the standard of care. But at one price, very important, at a price of a selection based on this workup phase, on this simulation phase. So how are we working in Montpellier? When we discussed during our multidisciplinary tumor board, we decide not to treat the patient with Y90. We decide to go to the simulation phase. And we look at 4 different parameters. The first one is we need to obviously to have no contraindication. For example, a large lung shunt. This is a contraindication. Obviously, we don't treat the patient in this case. But we have 3 additional questions. Can I obtain a complete tumor coverage? This is very important. Can I deliver a high dose to the tumor? And now we have the thresholds we need to reach to make sure that we will become efficient. And we need also to have an hepatic reserve greater than 30%, following the same concept that you follow in surgery of cirrhotic patients or non-cirrhotic patients. I mean, you leave some liver volume not treated, and you leave some liver just to make sure that the post-operative period will be okay, and there is no problem for recovery. So we follow exactly the same concept. By doing that, if we can answer yes at these 4 questions, then we go for Y90 or CERT. And otherwise, and we use the other drugs as second-line treatment. Otherwise, if there is any problem, for example, if I can't deliver high dose to the tumor, or I can't preserve some at least 30% of the liver parenchyma, then we go to the standard atezobev and the other drugs. This is our algorithm. The second question we can raise is about surgery of this poor prognosis HCC, because as you know, when we have portal vein invasion, there are some papers showing that if you resect this patient, you can obviously, but if you resect this patient, the results are very poor in terms of overall survival and really looks like the results of sorafenib. But now what happens if before surgery, we use radioembolization as a downstaging strategy? In the trial published in Lancet Gastro, we had, as discussed previously, a very huge response rate, very large, very long survival. But look at that, we could resect 36% of patients who were randomized in the personalized dosimetry arm, versus only 4% of those patients who were randomized in the standard dosimetry arm. Remember, the standard dosimetry is the dosimetry used for past phase 3 trials. And most of these resections were R0 resection. Why YNIT is interesting as a downstaging strategy? For different reasons. The first one is that we need really to wait. We need to treat the patient with YNIT and then we just follow up the patient. Why? For 3 reasons. The first reason is that there is a slow effect of YNIT, a slow effect of radiation in general. It means that you need to wait for at least 3-4 months to get the maximal effect of YNIT. That's the first point. The second point is that you will get contralateral hypertrophy. You can see here very well. We have treated with YNIT the right part of the liver. You look at the left part, with this huge increase, and this, on the contrary, this atrophy of the right liver lobe. That's the reason, the second reason. And the last reason is probably, in my view, the most important one. We have a very interesting test of time, meaning that during this time needed for the efficacy, to get the efficacy of YNIT, to get the contralateral hypertrophy, we have a close look at what happens in this part of the liver. Is there any new HCC growing nodule? If yes, probably we have an aggressive tumor biology, and it's probably not a good idea to resect. On the contrary, if in this lobe you can see no growing nodule, then this is a very good moment to resect the patient. So this test of time is very important to select and to help to select good patients for surgery. This is a typical example of that. You have here a patient, BCLCC, with an infiltrative HCC in the right lobe with portal vein invasion, very good liver function. He's a young patient, and we decided to do the workup phase, the simulation phase. As you can see, we have very good coverage of the tumor, but also of the thrombus. We could deliver a high dose to the tumor in the thrombus, and we could preserve all this parenchyma, so we had enough hepatic reserve. So all lights were green to treat the patient with YNIT. And we treated the patient with YNIT. Look at what happened. You can see here at 3 months that the right liver lobe has decreased, has shrunk. And you can see here the portal thrombosis, which has become hypodense because of and much smaller than previously. And at M3, we are here. And if we look at the future liver remnant, it has increased as well. And then we did a volumetry. In this case, we also did a nephrophenin scintigraphy. And because the FLR was enough, we decided to resect the patient. And we were right because we had a very, very good pathological response, but not complete pathological response because it remains some submillimetric foci of HCCs. And now these patients, we are 4 years later, and is still alive without any tumor recurrence. Remember, at the beginning, we were here, very poor prognosis. This patient should have been treated by atezolizumab, bevacizumab, 14 months OS. And now we are here, this is the same patient, and we are 4 years later, and he's still alive without any recurrence. So clearly there is a place for Y90 to make the patient resectable. That's the reason why in this work, and this is one of my last slide, in this work, it's a very recent work just accepted in HBSN, we looked at our experience with this poor prognosis HCC, large HCC more than 8 cm, or multifocal HCC, or HCC with portal vein invasion, first downstage with Y90, and then operated. And if you look at the results, so they were operated at a median time of 6 months after surgery, as explained before. We had no mortality from surgery. Interestingly, we could see 36% of complete pathological necrosis. So even in this poor prognosis tumor, Y90 alone was able to provide a kind of curative treatment. Interestingly, the greater the dose and the greater the effect, again, it's not surprising, but what was really surprising is that 61 or 62 months OS, this is exactly the same prognosis than patients with very small HCC that are ablated, who are ablated or resected. So very, very good prognosis and very, very long PFS for these patients. Remember, at the beginning, they had very, very poor prognosis. So Y90, in my opinion, is an excellent weapon to downstage or to bridge to surgery. And this was my last slide. Thank you.
In presentation and impressive results. I don't know.
So interesting, yeah.
Professor Mansour, yeah.
Thank you very much. Very enlightening presentation. Thank you very much. I have a couple of questions. One related to the venous deprivation. In one of the slides, you talked about the translational part. Any biomarkers that can predict the outcome? So this is the first question about the venous deprivation. The second question about Y90. The SARA study and the Asian Pacific looked at the two treatments, the TARE and the systemic treatment, as comparative arms or opposing treatments. Would it make sense to use new adjuvant systemic treatment, such as atezo-beva, select the patients, and in that setting, introduce Y90? Because we have the problem of that subset that has vascular invasion. And there is always this dispute whether the vascular invasion patients will benefit from any kind of local treatment. These are my two questions.
A very interesting question. If you agree, I will start with the second one, because it's a very interesting question. In my view, there is no competition between treatments. When we face an advanced stage HCC, I mean, obviously, no metastasis, but if we take the example of portal vein invasion, it's a good example. If we follow the recommendations, we should treat the patients using systemic therapies, for sure. These are the recommendations. But when you look at their results, even for the most recent ones, the median overall survival of this patient is very poor. Anyway, 14 months with atezo-beva. And in my view, there is no competition. There is only a question of sequencing. This is one question. So you suggest first to treat the patient with a systemic approach, why not? And then to use a local regional approach to increase the response. That's your meaning, right?
That's right, yes. But in the context of a clinical trial, because
yeah, you're right, sure. So in clinical trials now, we are in the field of immunotherapy. So we need now to, for the following studies, we need to incorporate and to evaluate potential combination, but also sequencing. And unfortunately, most trials in advanced HCCs And even the most recent ones just communicating at past ESMO meeting last week, there was only drugs versus drugs. And if we look at these trials, IMbrave 150 and the two positive trials that came up during the last ESMO and ILCA meetings, if you look at the forest plots, and if you look precisely at these results in patients with portal vein invasion, in these two groups, these trials are negative. Or it's not the right way to say, these trials show no obvious benefit in this population of PVI patients. And that's true for all of them. I don't know why. Maybe the reason is that between 20 and 35% of patients had portal vein invasion in these trials, and probably the power for such subgroup analysis is much too low. But anyway, if we look at IMbrave 190, LEAP-02, etc., the other one coming from China, also positive, each time the confidence interval incorporates 1 for PVI patients. So I'm not really convinced that systemic treatments are really helpful in portal vein invading patients because of that, and because the pure results even of atezolizumab are not really attractive. 14 months is not really attractive. On the contrary, with Y90, we can reach more than 20, sometimes more than 30, but at the expense of a selection, meaning that Y90 is not efficient in every patient, but is efficient in those patients for whom we first perform the workup phase, and we can see that the tumor coverage is okay, the dose will be okay, and there is no contraindication and enough hepatic reserve. With these 4 conditions, we got very good results, much better than drugs, but I agree with you that we should prove that in a trial. But the problem for us is who will sponsor such trials, because pharma companies are not interested for sure, and our companies don't want to conduct such trials because they are very expensive and they don't have enough money. And that's a shame, because for the patients, I think that it would be helpful first to select them with the simulation phase and see if they are a good candidate for Y90. Then we go to Y90 and then we use systemic treatments. And if they are not, based on the simulation phase, they are not good candidate to Y90, they go directly to the systemic treatments. And it makes sense.
This, this model of local regional treatment, TACE plus sorafenib, all the studies have been negative, but I wanted the reverse, the systemic treatment, for those especially with the beat, and then local regional treatment.
Yeah.
Thank you very much. Thank you.
And for your first question, regarding the biomarkers, and you mean biomarkers of regeneration, right?
Yes.
Okay. It's a very good question. What we could see when we were lucky enough to have mebrofenib is that there is I would say, a consistent increase in the function of the future liver remnant based on the initial future liver remnant function. I mean, when we did the mebrofenib scintigraphy, we could see, for example, the future liver remnant as a function of 1.7% per minute per square meter. That's the unit. And we know that we need to reach 2.7% per minute per square meter. So we know exactly how much we need more to make the patient resectable safely. And with this technique, what we could see with venous deprivation is that there is a consistent increase. So we know that between 1.7% to 2.7%, we can make the patient resectable at day 7, no doubt, and no exception. The problem is for patients with lower initial future liver remnants, because we have some not a lot. We have something like, I don't know, 5% of patients with very, very, very poor baseline future liver remnants. And in those patients, even with venous deprivation, it's not enough. And we had to find something else to make them resectable at the end. So the biomarker is so far an imaging biomarker based on the function. But during the trial, we are collecting many biological samples to see if there is something, I don't know, an interleukin or hepatocyte growth factor. We are collecting all this data, and we will see if one could be helpful to predict regeneration or not. But it's a little bit too early to give you the results.
Thank you very much. Thank you.
Thank you, Professor Guyo. It's really very interesting presentation. We enjoyed it a lot. Just coming back to this first question that you answered, Professor Mansour. What do you think of combining, in fact, both? I would say the TARE and the systemic therapy at the same time. Is it something visible, or is it? What do you think about it?
Yeah, to be honest, we have designed a trial like that because, again, I think that we are now in a new world, and systemic treatment, and especially immune checkpoint inhibitors, are really now, I would say, for a long time in the guidelines. So we need to also to think about potential synergies, because there are some data, not too many data, but there are some data showing that some of our techniques may have synergies with immune checkpoint inhibitors. We have data on ablation. We know that ablation, and especially radiofrequency ablation, is a very good technique to trigger anti-cancer immune response. We have some data on TACE, which could also be a good trigger for immune response. And for TARE, there are a little bit less data, but we have one trial which has started which is about to start in the US, called RO1. This study also enrolled some European centers, and we are taking part to this study. And we are also proposing a randomized phase 3, where we compare systemic treatment versus systemic treatment plus Y90 delivered at the same time, just to get potential synergies. So I think it's a very important question. If we look at the TACE world, in chemoembolization, we have something like seven trials ongoing. Some of them are combination trial, so TACE plus immune checkpoint plus tyrosine kinase inhibitor, for example. And we have also competition trials, because we have TACE versus checkpoint plus anti-angiogenics, and so on. So we have many combinations to test, and also many sequences to test. So a lot of work to do for the next coming years.
Thank you. Another question. Did anybody, for example, or do we have an idea for those patients who were, for example, I would say going for TARE, and comparing the results in those who have high alpha-fetoprotein? Do we see any relation between the two? Because, for example, in resection, sometimes we said if alpha-fetoprotein is very high, we need larger margin of resection. Do we see, I would say, any correlation between the two subjects? The level of
can you just summarize your question, because unfortunately the net connection was really bad, and I lost part of your sentences.
Yeah, I would say the results of TARE in patients who have, for example, high alpha-fetoprotein. Do we see any difference?
It's a really good question. AFP is, I would say, always a prognostic factor in every studies, in every case. In our series, we had some patients with very high alpha fetoprotein level, and the response is when the disease is really located in a lobe, and we can deliver a very high dose to the lobe, whatever the AFP level, it drops, and at the end it comes to a normal range, and the prognosis seems to be still good. But the problem is for those patients with a disease located to one lobe, but microscopic spread is not visible, but is present in the contralateral lobe. And for these patients, unfortunately, the prognosis is bad. But what is interesting with Y90 again is this test of time, because especially in this patient with high AFP level, if you do a Y90 in the right lobe, for example, and if you look at what happens in the left lobe during the next 6 months, and you see no HCC growing nodule, then probably you might hope that everything was located on the right, and with Y90 and then with surgery, the prognosis will be quite good. On the contrary, with high AFP level, you treat the right lobe and the AFP is dropping, but not going to normal range, and you can see some nodules growing in the left lobe, then you are happy not to resect, because probably useless, pointless, probably.
Okay. Thank you.
I had a question, a technical question.
Dr. Rashid is the head of radiology, diagnostic and interventional radiology in our center.
Very nice presentation, Prof. I just had a question in regards to the hepatic vein embolization. The image you showed was more like a percutaneous access. Do you do transjugular approach also?
I'm sorry, I can't hear you anymore.
For the hepatic vein occlusion,
Yeah.
for the hepatic vein occlusion, do you do a transjugular approach, or it's mostly percutaneous access?
Right, very good question. We do prefer using a full transhepatic approach, but okay, the reason for that is, for me, it's much faster, because it's, in most cases, except if you have a huge tumor burden in the right lobe of the liver, and in this case, it may be difficult to find a way for your needle to access the veins. Except in these cases, the transhepatic approach goes very fast, because you can select very easily the veins, puncture the vein, put the plug, put the glue behind, and that's all. If you use a transjugular approach, it's a little bit longer. Some catheterizations may be not that easy. For example, for accessory veins, sometimes you're not very stable, and you can put a plug, but it's difficult to imagine inserting glue, for example, in addition to the plug. Sometimes it's not so easy to differentiate between right and middle hepatic vein, but you can do as well. I think that the approach, if you prefer going through transjugular, it doesn't matter. You do what you prefer. Personally, I prefer the transhepatic approach, but in some cases I did a transjugular approach. But in this case, because I really want to inject glue behind the plug, with a transjugular approach, you need to put a catheter in parallel to inject glue behind the plug. But it's completely feasible, and I would say you use the technique you prefer.
I wanted to allude on a point that you've really covered very well, like a message to our medical and surgical oncologists, that the Y90 treatment is a slow growing treatment, and then the treatment results could be seen in 3 or even up to 6 months. So they just need to be patient with this mode of treatment.
The patient needs to be patient.
Absolutely. And again, I think this is a real advantage because during this time, we have the test of time, and this is important. And it's very different in the context of colorectal metastasis, for example, because in this case, usually the patient has systemic treatment and we have downstaging of the mets. And then when thinking about resecting the metastasis, but we know that we have a very short window to do that because we probably stop chemotherapy. We need to do portal vein embolization or anything else just to help you to have enough future liver remnants. It takes time, and we have a very, very limited window. With HCC, if you use Y90, you treat the whole tumor, and then you have time to wait. And it's good news because after this 6 months, you've got full effect of Y90 in terms of downstaging, and you have seen if the patient is a good candidate to surgery. It's a completely different world from the metastatic colorectal setting or context, in my view.
Thank you, Professor Bouyo. I don't know if anybody has another question.
Yeah, Abdullah, I have a question if it's possible. Again, it's more technical.
Yes.
Thank you, Prof, for your amazing presentation. I just had a question regarding the workup with the pre-workup prior to TARE. So does that by default always include functional imaging with mebrafenib, or do you have selective cases where you would then also do a pre-workup with mebrafenib in addition to the MAA? The second question is, as you said, one of the main contraindication is when you have a high liver lung shunt. And usually we do this with planar imaging, but there are papers that allude to doing SPECT calculations, which can be more accurate. And actually, those who might have deemed having a higher shunt on SPECT would have shown, smaller shunts. Do you think that is something to move forward in terms of calculating these shunts? Would just like your experience with that.
Okay, again, I'm sorry, I have some really poor connection and some part of your sentence is lost. I'm sorry. The first question I heard was about mebrafenib and Y90. It's a very, very good question. We performed a study where we, in a series of, I can't remember the number, I think it's 16 patients. We did mebrafenib at baseline at 1 month, 2 months, 3 months, and 6 months after treatment, just to look at what happens in terms of function in the treated liver and in the non-treated liver. And this study, I should have showed you the results. Sorry, this study is interesting because we could see that the part of the liver treated by Y90 decreased its liver function by 60%, but slowly, but reached minus 60%. And we could see that the function of the future liver remnant increased by 60% as well, but at 6 months. And meaning that we can get very good regeneration, but we need to wait. But what was really surprising for us is that when you treat the right liver lobe, for example, with Y90, and you look at the function of the left lobe, so not treated, the function of the left lobe is also decreased by 20% during the first 1-2 months. And it was really surprising to see that. So you irradiate the right part and something happens in the left. It's just unexpected. And probably there is the reasons are based on they're behind immune markers or growth factors, etc. But we don't know really why. But the objective from this study was to try to improve the model of safety for radioembolization, because nowadays, and as I explained you in the presentation, we are just looking at the hepatic reserves in terms of volume, but clearly it is not very precise. And I think we can certainly do better than that and take into account the liver function and have a model of liver function modifications following Y90 to really personalize and optimize this treatment. But this will be for the next coming years. So for daily routine practice, we don't use mebrofenin. And also because, unfortunately, again, in France, we don't have mebrofenin anymore because of shortage today. But for daily practice, I think it's not really, I think it's interesting, but probably within a study, prospective study, not for routine practice.
Thank you, Boris. I think that we could create the joint venture between Montpellier and the radiology department. What do you think, Professor Mansour and Rashid? I think
we'll be very keen to establish cooperation and collaboration between our radio imaging center and your prestigious center. We have a lot of HCC in Oman. Most of them are in the advanced stages, and most of them are related to hepatitis B and C. So I don't know, in your patients, maybe, or in your population, it's mainly probably alcoholism or whatever. But in our population, it is hepatitis. So it might make a very good comparative arms
Absolutely.
study. So I would welcome that. And I think Dr. Rashid, Dr. Khulud would welcome any kind of collaboration, both in terms of technical study or drug studies or molecular studies. We are also happy to help with that.
Okay, very good news. And I would be very happy to work together. Sure.
Thank you very much.
Thank you. Thank you. Thank you.
Thank you, Professor Duyo, again. We took a lot of your time, and if nobody,
It was a great pleasure.
Thank you very much.
Okay. Thank you all.
Thank you.
We keep
Thank you.
in touch.
thank you,
Looking forward
Boris.
to
See you
collaboration.
on
Merci,
Saturday.
Fabrizio.
Yes, see you on Saturday. Thank you.
Thank you. Merci. Bye-bye.
Au revoir. Au revoir. He's a scientist, very impressive every time.
Dr. Rashid does a lot of care and